Hi, my name is Ross Milner. I'm a vascular surgeon at the University of Chicago. Artificial intelligence has become a bigger part of many of our practices. And I think for many of us, we still struggle a little bit understanding what artificial intelligence is and how it impacts what we do within our specialty. My experience with artificial intelligence has grown a little bit with what I've done, both with SIDAR mapping, which we do intraoperatively, which is a form of that, and as well as some research that I've started to do with a company called VEITH, looking at aneurysm surveillance and potentially aneurysm care. And so I think for many of us, we hear artificial intelligence and think of many other things other than vascular surgery, but it's definitely starting to impact what we do on a daily basis. In addition, I think what we're starting to understand is when you're able to take this and look at patient populations, that we can start to make better predictions of who may do well with certain procedures. So it's not just looking at the individual patient like I'm talking about with SIDAR or with VITA, but looking at larger groups of patients and understanding outcomes and potential treatment paradigms based on that. So I think many of us are still learning exactly how it will impact our practice, but I do see that it's starting to impact us now, and will have even a bigger impact, I think, in the future. So currently, I use AI for some of the imaging that we do. We also use it for our research. So I'll be more specific with both. So we use AI with the current procedures that we do in the operating room, with the imaging that we do, and we're also starting to work with an investigational tool to understand potentially endo leaks and how we could better predict who will have problems either with their aneurysm pre-treatment or with their aneurysm repair that's been done afterwards, and try to understand better. But as well, we use it for machine learning here with research that we're doing. And we're doing a lot of work on aortic dissections and have some outstanding computer modeling and simulation that's done through computer modeling, but starting to be able to allow that to be done in an automated way through machine learning. So we're incorporating artificial intelligence, not just what we do clinically, but what we're doing from a research perspective as well. So some of the recent developments that we've seen with AI and knowledge, I mentioned a little bit earlier in the interview in terms of a company called VITA. It's a company that I am on the scientific advisory board for. Randy Moore, a vascular surgeon out in Calgary, has worked very closely with a scientist to develop paradigms to better understand aneurysm risk of rupture, and also, as I mentioned before, but our potential for predicting who is going to have problems. And so this is still early on in their experience, and it's going to grow. And I think as we get more and more knowledge from this, will be very valuable. And this was presented at the VEITH meeting this year, and live in New York City and in person. And I think we're going to continue to see more and more data come from this that will help us predict for our patients who will benefit from treatment and how the outcome of the treatment we've done, how successful that outcome is. The future prospects, I think, are fantastic. So, I think we'll continue to get better with our imaging and allow for better, not just intraoperative imaging and changes that happen intraoperatively, but predictive, as I've mentioned. And as well, I think we'll continue to be able to refine what we do from a research perspective. And the advances we've made in the past decade with our imaging and what we've learned from artificial intelligence and machine learning and the deep learning that's occurred, I think we'll be able to impact more patients in a positive way. So I think for all of us, it's a little bit intimidating at times when we first hear these terms, because they're new for us and they don't fall within the realm of what we typically think about within vascular surgery. But I think more and more as we get accustomed to what the benefit is and how this can be applied to our patients and what we do from our clinical care and from our research, I think we'll continue to be more comfortable with it and see the value of what can be gained for our overall patient care and research experience.